So good morning, everybody.
Good morning.
I have 5 minutes to tell the story of Nigeria FETP Alumni Association. I don't think it's enough time, but I'm going to try. I'll be sharing experiences on the role of the Nigeria FETP Alumni Network in health system strengthening. So which one is it now? So background. So the Nigeria Field Epidemiology and Laboratory Training Program was established in 2008 as an in-service training strategy to build capacity within the public health sector for disease surveillance, response, and other public health priorities. So its goal, right from the beginning, was to build capacity within government institutions. It was a health system strengthening endeavor, if you like. Therefore, only health workers already working in the ministries, departments, and agencies were eligible to apply. And right from the beginning, guided by the One Health paradigm, the program recruited trainee epidemiologists into 3 tracks: medical, vet, and laboratory. It was hosted by the Federal Ministry of Health and the Federal Ministry of Agriculture and Rural Development. There were 2 collaborating universities, Ahmadu Bello University, Zaria, in the north, and the University of Ibadan in the south. These 2 universities have been awarding MPH degrees to the graduates of the program. The program has been governed by a steering committee chaired by the Director of Public Health in the Federal Ministry of Health. Since its inception, the program has recruited, trained, and graduated 11 cohorts. When the program rapidly increased the cohort size as it recruited the 3rd cohort, there was an acute need for mentors. The cohort 1 alumni were immediately called upon, and they rose up to the challenge to help mentor the epidemiologists in training. The Field Epidemiology Alumni Network, in service of public health priorities, had been born. The practice of FETP alumni giving back to the system by mentoring the residents has continued to this day. This has been a major function of the alumni network of the Nigerian program. Now, by 2012, 4 years into the program, Nigeria was still one of the few countries in the world endemic of the wild polio virus. The National Stop Transmission of Polio program was established in July of that year, 2012. And it was implemented by the African Field Epidemiology Network with the technical and financial support of the US CDC in response to the National Polio Eradication Emergency Plan developed by the government of Nigeria to strengthen the Nigerian polio eradication program at the operational level. Now, leveraging the existing Nigeria Field Epidemiology Laboratory Training Program, the purpose of NSTOP was to provide Nigeria with high quality and culturally competent technical field support staff in high-risk areas to implement the polio eradication emergency plan, and accountability framework, and strengthen routine immunization. The first set of epidemiologists trained were alumni and residents of the Nigeria FETP. And since inception, the program has tapped into the existing network of FETP alumni for epidemiologists to run it at the national and sub-national levels. In fact, the current national and deputy national coordinators are alumni of FETP. Same with all the field coordinators in the high-risk states. And NSTOP has played a significant role in the interruption of the transmission of wild polio virus in Nigeria, for which Nigeria was certified in 2020. The program continues to strengthen routine immunization to control other vaccine-preventable diseases, as well as respond to circulating vaccine-derived polioviruses. Now, when Ebola was introduced into Nigeria in 2014, the alumni network of the Nigeria FETP, working in NSTOP, and from other programs, ministries, and agencies in the country were mobilized, as well as current trainees. Over 100 graduates and residents were involved in the initial rapid response to the index case, rumor logging and investigations, case management, innovative contact tracing using ODK for real-time reporting, enhanced surveillance, capacity building, operational research, and assessments. After halting the spread of the Ebola outbreak in Nigeria, several graduates and current trainees of the Nigerian program went to Liberia and Sierra Leone to help fight the outbreak under the auspices of the African Union. In 2015, graduates of the Nigerian Field Team got together, had elections, developed a constitution, and formally launched the Alumni Association. Well, I must admit that the association itself has not been very active as an organization. However, the network of alumni has been very strong. We have a Telegram group as well as a WhatsApp group where we exchange news and information, ideas on ongoing public health priorities, job and continuing education opportunities, and so on and so forth. Then when we began to roll out the frontline FETP, which is the basic tier of the FETP in Nigeria at the beginning of 2016, we never lacked for instructors and mentors to train large numbers of surveillance officers. We once again tapped into the alumni network for more than 95% of the trainers. So between January 2016 and August 2018, we trained more than 1,100 surveillance officers in about half of the states in the country. Now, the Nigeria Center for Disease Control was formed in 2011, and by the time it properly took off as Nigeria's National Public Health Institute, alumni of the program already working in the ministry were deployed to support the organization. And within a short period of time, most of the technical working groups of the NCDC, such as yellow fever, Lassa fever, and the rest of that, were being led by alumni of Nigeria Field Team. Right now, 2 of the main departments of the NPHI, epidemiology and surveillance, and planning, research, and statistics are headed by NFILTIP alumni. And of course, we've had people in different positions. A past chief veterinary officer, we've had a state commissioner of health, we've had several state epidemiologists from the ranks of the alumni. We currently have permanent secretaries at the national and subnational levels who are alumni, and many alumni are officers in specific disease control programs at the national and state levels, such as malaria, tuberculosis, and HIV. Alumni of the Nigerian program were among the first set of facilitators and mentors in the Sierra Leone FETP when it started, same with Liberia and Gambia, and the resident advisor of the Gambian program, the resident advisor of the Botswana program are alumni of the Nigerian program. And of course, the alumni have done a lot of work with specific disease control programs such as malaria, where they supported the program to develop the National Malaria Operational Research Agenda, and also to develop a malaria short course focusing on malaria program officers at the subnational level. Then quickly, the Nigeria Field Team played a significant role in the national response to the COVID-19 pandemic in the country. AFENET staff, Field Team fellows, graduates, were part of the preparedness technical working group that adapted the influenza pandemic preparedness plan to develop a pre-incident plan. In fact, the technical working group was headed by a graduate of the program, and alumni and residents were deployed to conduct screening and surveillance at the airports, as well as monitoring of passengers of interest. And alumni working with AFENET and collaborating with Africa CDC and Nigeria CDC conducted the training of IPC focal persons from several countries in Africa in preparation for the first case in those countries. And of course, when the cases came up and the EOC was formed in Nigeria, many of the pillars were led by alumni of the program. And of course, when the presidential task force was formed, alumni of the program were chief technical officers running the task force. And of course, as the Africa CDC responded at the continental level to support member countries, alumni of the Nigerian program were at the forefront. Many of them were deployed not just in Nigeria, but with Africa CDC HQ, as well as other member states like Sierra Leone. And we also tapped into the network to provide Africa CDC with epidemiologists to support the COVID-19 vaccination rollout in Nigeria and many other countries such as Rwanda, Tanzania, and the Gambia. And others have been deployed to Addis, Somalia, and Kenya. So you can see that the Nigeria Field Team alumni have been relevant in the Nigerian public health scene. Alumni have been utilized to respond to public health emergencies and other public health priorities. We only ask that the government of Nigeria be committed to ensuring that recruitment and training continue in order to maintain the pool of epidemiologists. Thank you for listening.
Mine is really to highlight some of the opportunities that we have within the mother of networks, AFENET, which is the African Field Epidemiology Network, that has supported multiple countries across the continent to initiate and implement field epidemiology training programs. And Zambia FETP being one of them. Next slide. So I'll just give an overview of what AFENET is, who we are, some of our strategic priorities that the Zambia Field Epidemiology Network could associate with and could leverage for their growth. I'll show the AFENET and our footprint across Africa. I've mentioned we're in 40 African countries. I'll walk through that. I'll also talk about our FETP coverage. We've been supporting countries for over 18 years and we've made progress towards addressing the field capacity gaps on the continent. Then I'll highlight a few opportunities that exist for FETP alumni across Africa. So AFENET was established in 2005 as a not-for-profit networking and service alliance of field epidemiology and laboratory training programs in Africa. And for over 18 years, we've been US CDC's principal implementing partner for developing, sustaining, and implementing field epidemiology training programs, including the Zambia Field Epidemiology Training Program. We work closely with ministries of health, ministries of agriculture, national public health institutes across Africa. Our vision is really to see a healthier Africa, and this can only be achieved through strengthening field epidemiology and public health lab capacities to effectively contribute to addressing epidemics and other public health challenges that we face as a continent. Our mission is that we are committed to ensuring effective prevention and control of epidemics and other priority public health challenges that we face as a continent. In terms of our strategic priorities that drive us towards the mission that I've stated and the vision, one is field epidemiology capacity development, public health lab capacity development, public health disease surveillance and effective response, public health program management and research development, networking and collaboration for public health advancement, documentation and publication for public health, and promotion of the One Health approach. Across all these 7 strategic priorities. So in terms of footprint, the Francis mentioned that they would like to network with other FETPs. This is where AFENET is, and we are supporting 40 African countries. So you have a range of countries to reach out to. And in these countries, we're implementing different levels of FETP. We have 16 member programs or member countries that are implementing the advanced FETP. We have 24 African countries implementing the intermediate FETP, which is the 9 months course, and 38 African countries implementing the 3 months frontline FETP. We have, in order to bring AFENET, which is headquartered in Kampala, Uganda, closer to countries, we have the regionalization strategy. And within the Southern Africa, we have a regional hub in Zimbabwe. We saw the regional technical coordinator here sharing the Zimbabwe experience. And so that serves as your immediate point of contact into the AFENET network to be able to support faculty exchange with other FETPs within the region, to be able to support you on documentation of your successes, to support you with accreditation needs for the program, and also building your capacities in your areas of interest. We've supported countries across the continent to train and build capacities in field epidemiology. To date, we have 2,834 graduates at the advanced program. We have 883 graduates at the intermediate FETP, and more than 10,000 graduates at the frontline field epidemiology training program. What are some of the opportunities that exist across some of our strategic priorities for FETP alumni? Under the field epidemiology capacity development, of course, we're still grappling with the issue of career path, career opportunities, but AFENET provides opportunities in the areas of field epidemiology capacity development. When many of these programs were starting, we entirely relied on experts from outside Africa to serve as resident advisors, to serve as field coordinators and mentors for FETPs. Now we have capacity. We've trained 2,800 epidemiologists at the advanced program. So there are job opportunities that keep coming up within the AFENET family that our alumni can take advantage of. Public health disease surveillance and effective response, we have opportunities for deployment to national, regional, and international response. AFENET has what we call the AFENET Cove Disease Detectives Accord, which is a platform for mobilizing and deploying FETP graduates and residents across Africa. So that is an opportunity for the Zambia Field Epidemiology Network. We are also part of the Global Outbreak Alert and Response Network, GOAN, and through GOAN we normally get calls for expert epidemiologists to be mobilized and deployed for regional and international response. So that's another opportunity for Zambia FETP network to explore and work with AFENET to take advantage of those opportunities. We're also supporting and working with the Africa CDC for the Africa Volunteers Health Corps. That is another opportunity for the field epidemiologists trained through the Zambia program to be deployed to support other countries that are still growing and lack that capacity to manage the challenges. Under our networking and collaboration for public health, we have scientific conferences. I'm glad Francis mentioned that as one of the achievements. We recently had our 8th AFENET Scientific Conference in Mombasa, and FETP alumni, residents and graduates, over 700 delegates were in that conference, and they were able to network and share experiences. And we'll still continue doing those conferences for our FETP networks. We have opportunities for professional development through pre-conference workshops, through pre-deployment orientations and trainings under the AFENET Cove Disease Detectives. Publication and documentation, we have the AFENET Journal of Interventional Epidemiology, which recently celebrated its 5th year. And we are glad in-house we have our managing editor. So the colleagues from the Zambia FETP network, please reach out to Dr. Shiba in case you need to document through the Journal of Interventional Epidemiology and Public Health. A few pictures from the fields. These are some of the FETP graduates, alumni that were mobilized and deployed to support a number of major public health challenges: the Ebola virus disease in Uganda, COVID-19 in Uganda, cholera outbreak in Zambia, and the DRC response to the 10th EVD outbreak. I mentioned about the Journal of Interventional Epidemiology as an opportunity for the Zambia FETP network and other FETP alumni across the network to document and publish the work that we are doing in the field. This logos is for our AFENET Cove Disease Detectives. Again, as I mentioned, it's a good opportunity and a platform for us to mobilize and deploy the FETP graduates across the continent. Thank you so much.
So good morning. So we'll move to the last session, which is the panel discussion. You realize we started late, so we'll have 45 minutes. But I know from the presentations, you have a couple of questions. So we'll have 10 or so minutes just before the closing remarks for questions and answers, just to make sure that we are talking, we are discussing, we are not just preaching. So with these few remarks, I want to recognize the CDC director, the UKHSA director, our director from the Global Health Center, and my mentor, Henry. Henry, while you're speaking, I recognized you as my mentor. And the other mentors, FELTIC is about mentorship, FETP is about supporting the system. And so we will have a panel discussion for the next 50 or so minutes to discuss how to support and strengthen and advance the use of FETP in Africa. We have close to 100 participants here, but also maybe 30 or so online participants. My name is Patrick Nguku. I work with AFENET. I'm a graduate of the Kenyan FETP, but I've worked with many of the other FETPs. We have a panel of very experienced experts who will help us think about how to consolidate all this. How do we sustain these efforts? How do we make sure that these investments are aligned with the bigger health system strengthening agenda, the universal health coverage, the value for money, the utilization. I hope the Zambian FETP have seen that one of the things you have to do is make sure that one of you becomes a minister. You've seen how Zimbabwe has done very well on that. But how to also deal with the bigger health emergency preparedness and response space. How do we continue building the fundamental foundational capacities, but also ability to surge during a public health emergency? And the 5 C's that WHO has mentioned in its framework for health emergency and resilience. Collaborative surveillance, how do we make sure it's One Health? Community protection, how do we make sure that communities are not overwhelmed by these emergencies? But also, how do you link up with clinical care and have the ability to surge when it's needed? Access to countermeasures, and the bigger issue about coordination. So in this 50 or so minutes, Dr. Noshon Gombe will introduce the panelists and they'll sit. And then we will ask them questions and they will answer. And because they are mentors, they're very well trained. They can package this in 3 minutes. You ask a question in 3 minutes, they will give you the right answer. And then we'll give you an opportunity to ask them questions so that it's interactive. And then we'll have final thoughts from our panelists. And then we'll sort of give the key highlights. And then Dr. Nyambe will give opportunity for colleagues to ask questions on the other issues that have been covered. So is this agreed?
Yes.
It is agreed. So let's target to be out of here by 11:45. So Dr. Noshon, please introduce the panelists.
Okay, so thank you very much, Patrick. I'll go ahead and introduce our panelists. Yeah, so as I was looking at the bios last night, I said to myself, if I'm to read this verbatim, I'm sure we'll need another side event just to look at the bio. So I've just tried to summarize this in the interest of time. So in no particular order, let me introduce our first panelist. Okay, so let me proceed. So Professor Ernest Kenu, maybe just by show of hand, Prof, just so that people can see you. Okay, he is a medical practitioner and an associate professor of epidemiology at the School of Public Health and Department of Medicine and Therapeutics, Medical School, both of the College of Health Sciences, University of Ghana. He's also a program director of the Ghana Field Epidemiology Training Program. He is also a board chair of the African Field Epidemiology Network, AFENET, and he serves as external examiner, moderator at postgraduate level for Kwame Nkrumah University of Science and Technology, University of Namibia, Pretoria, and Cape Town. He is a member of a team of established and single largest of a team that established the single largest ART clinic in Ghana with over 20,000 clients and involved in several pharmacokinetic studies, including the groundbreaking pharmacokinetics. He has vast experience in regional and program-specific strategic plans development, and is a member of the country coordinating mechanism, oversight member, and serves on the Stop TB Partnership in Ghana board. Over 100 publications in peer-reviewed journals. So please, delegates, help me welcome Professor like I said, in no particular order, our second panelist, another experienced individual, is Dr. Ashley Sharp. Dr. Ashley Sharp is the director of UKHSA. He recently moved to Lusaka as country lead for the UK Healthe Security Agency team in Zambia. He trained and worked as a medical doctor in the UK before specializing in public health. He previously worked with the UK Healthe Security Agency team in Ethiopia, supporting Africa CDC's work in emergency preparedness and response across the continent. He has extensive experience in outbreak response, both in the UK and internationally, including several deployments as senior epidemiologist within the UK Public Health Rapid Support Team. As a graduate of the UK Advanced FETP and an FETP supervisor, Dr. Sharp is a strong advocate for applied epidemiology training to strengthen the public health workforce globally. Dr. Sharp. Our third panelist is Dr. Simon Antara, who is the director of AFENET. Dr. Antara is a medical epidemiologist with vast experience in public health practice and applied epidemiology in both the non-profit and public sectors. Before his current appointment, he served as a director of programs at AFENET. Dr. Antara has served as resident advisor to a number of FETPs in Africa. These include the Rwanda FETP, Namibia, and West Africa, which is a regional program for Francophone West Africa, based in Ouagadougou, Burkina Faso. Dr. Antara has expertise in leadership, program management, monitoring and evaluation, surveillance, emergency preparedness and response, training, mentorship, networking and collaboration. In recognition of his commitment to work and service, he has won several awards as a student and as a practitioner. These include the US Ambassador's Award for Exceptional Dedication and Technical Excellency for supporting Namibia to respond to critical public health threats in 2013. Dr. Antara represents AFENET on the steering committee for the Global Outbreak Response and Alert Network, GOAN. He is also a member of the board of directors of AFENET. Please help me welcome Dr. Antara. Okay, our next panelist is Dr. Samuel Jacob Obwa, who is a TAFENET representative. Dr. Samuel is currently a program management team lead with the Task Force for Global Health in Atlanta, Georgia, where he is assigned by the Training Task Force for the Training in Epidemiology and Public Health Interventions Network, TAFENET, to work on the Global Fund Strengthening Outbreak Notification and Response Project. Before now, he had cumulatively managed portfolios of over $200 million public health projects in very senior leadership positions in Africa. Samuel had served as the country director of the USAID-funded Health Workforce Management Project in Nigeria. Some of his previous roles include Deputy Project Director of the $100 million Global Fund Comprehensive HIV/AIDS Prevention Care and Treatment Project in Nigeria, implemented by FHI 360. As a program specialist with the US CDC in Abuja, Samuel led the initiative to establish the West African Infectious Disease Institute in Nigeria and had managed the US CDC cooperative agreement to AFENET for the establishment of the Nigeria FETP. Samuel recently served as a technical officer with the Nigerian Presidential Task Force on COVID-19. He is a multiple award winner, including the United States Department of State's Individual Franklin Award for outstanding commitment and dedication in support of human capacity development in Nigeria. Help me welcome Dr. Samuel, please. So last but not least, we have Dr. Kyla Lasson, who is the US CDC Global Health Center Director. Kyla is, where she leads the CDC Global efforts to protect and improve health through science, policy partnership, and evidence-based public health action. Prior to becoming the director of GSC, Dr. Lasson served as the deputy director for infectious diseases and vaccine delivery, India office of the Bill and Melinda Gates Foundation. Before her role at BMGF, Dr. Lasson was the CDC India country director and the CDC Indian Division of Global Health Protection Program Director for 6 years, based in Delhi. Dr. Lasson also served as the director of the Kenya Medical Research Institute / CDC Research and Public Health Collaboration in Kisumu, Kenya, from 2006 to 2013. In addition to her work in India and Kenya, Dr. Lasson has worked extensively in Mexico, Brazil, Russia, Latvia, and Vietnam. She holds a bachelor's degree from the Harvard College and Doctor of Science in Infectious Disease Epidemiology from the Harvard T.H. School of Public Health. And Dr. Lasson served as a commander, I thought I should say this, it's unique, served as a commander in the Public Health Service Commission Corps until 2007. Please help me welcome Dr. Lasson. So now we have our full bench of esteemed panelists. I'm sure we can go ahead.
So we'll go straight to the questions. So we'll start with questions from us and then questions from the audience. So Professor Ken, what strategies can countries employ to ensure retention and motivation of trained and skilled FETP to continue health system strengthening and health security needs at all the levels of the healthcare systems? Retention and motivation at all health system levels. Over to you, Prof.
Thank you very much, Patrick. You know, when you are asked a question for the first time, you keep wondering whether you should stand up, because as a teacher, what you are used to is to stand to talk. Now, when you are sitting, you're wondering whether you're supposed to. Well, but more important, thank you very much for your question. Now, one thing I want to bring to all of us our attention is to motivate somebody to retain an individual. There should be, first and foremost, the need to create that environment where the person feels needed. If you don't feel that I'm needed in a particular place, you don't feel like you should stay there. So my few points that I have here, the first point that I have noted down is that we should make sure we create what FETP professionals will feel that they are needed. And that can only be done through creating a supportive work environment. What do I mean by that? You know, we need to value their contribution to the work that they do and also their well-being. Sometimes you are interested in the work that the person is doing, but not interested in the person's well-being. And that is very crucial. In addition, we should make sure that they have access to the necessary resources and equipment that will promote a balanced work life. That would be my first point. Please, let's make sure they feel needed. You will stay when you feel that I am needed in a particular place. But if you feel I am just an add-on, an entity in there, you don't feel like you should be retained. My second point, which is so crucial, is about where they are deployed and the role that they play. Deploy a person to a place that he plays a critical role. When you are playing a critical role, you feel you are needed. And what it means is that you want to stay there forever. Now, if you place them in key positions, and in these key positions that you place them, what they are doing is to ensure they contribute significantly to the health system and also to the health security. Believe you me, they will stay. But if the person doesn't have any key position, any critical position, I don't have any need here, I don't have anything to do here, they will leave. And that is why we need to create and also deploy them in critical roles in their various countries. My third point, I keep saying that we always do after action review. Is that not correct? But when it comes to FETP professionals, we don't do that. My after action review, which is the AAR, is actually we should acknowledge, we should appreciate, and we should recognize them. When you appreciate somebody, when you acknowledge people, and you do recognition, they feel part of the family. We don't have this happening. And to me, if we can make sure that the achievements of FETPs and the alumni are acknowledged, we put in a proper approach to award them. Even at public or international forum, we are able to acknowledge what they have done, and there's a clear advancement in what they do. They feel part of the family, and they will stay. But if you don't feel part of the family, if you are not recognized, if you are not acknowledged in anything, what is the need for me to be motivated and stay there? The fourth point that I have here is having a clear professional development opportunities. When you have a clear path, when you know where you're heading towards. And this we can do by making sure that we invest in ongoing training, we help them to attend conferences, we support them in terms of fellowships, because knowledge is not stagnant, it keeps changing. And the only way people will feel part of a system is when they constantly train and gain new knowledge. The other one that I have here is that, we talk about mentorship when it comes to FETP. But the mentorship that we've all been talking about is not well-defined mentorship program. I believe that if we have a well-defined mentorship program for FETP professionals, this will help them to be maintained in their various countries. Now, how do we do this? We do this by making sure that the various countries have experienced field epidemiologists. Make sure these field epidemiologists guide them through their early part of their career. Let them know that, I'm part of this big family. My sixth point that I have here is that we talk about networking. But the networking, I should round up, right? Yeah. You see, when you give a teacher the opportunity to talk, when you're right. So to round up, I think that we need to make sure that we have a robust networking and collaborating, and also we support them in research and publication. Don't forget that everybody wants to contribute to the knowledge, and the new knowledge can only begin through research. So support them. The last point, which I want to make, is that, which I didn't mention, which everybody expects to be mentioned first, had to do with clear career progression and competitive compensation packages. You see, when you don't give them the adequate resources and the monies that they require, they will leave. But I mentioned the earlier component first, because you can give somebody money, but if the environment is not good, they will leave. That is why the money is the last one. Thank you very much.
Thank you very much, Prof, for that. So we'll proceed to the next panelist. Of course, there will be a session to discuss further and also ask questions to our panelists. So let me just remind our panelists, it's just 3 minutes, and I'm sure So the next question is Dr. Kyla. How can we improve utilization of trained FETP and other skilled public health workforce to ensure IHR core capacities are improved? Dr. Kyla.
Thank you very much. And thank you for the invitation to be here. Just before I answer the question, just wanted to say that what was not in my bio was that I am a graduate of the CDC EIS program, which is an FETP program, and I had the great joy of working in the Kenya FETP program and in starting the India FETP program. So I'm a big FETP person. I'm very happy to be here. So I think the question was how to use FETP graduates in IHR work. Was that right?
So let me repeat it for you. How can we improve utilization of trained FETP and other skilled public health workforce to ensure IHR core capacities are improved?
Okay, great, thank you. So in terms of IHR core capacity, surveillance, EPI, being able to respond, pandemic preparedness, I don't want to repeat what the professor has said, but a lot of it is similar because if we have graduates that aren't being pulled into government and being pulled into the Emergency Operations Center, into surveillance, into the data systems, into outbreak response at the country level, then they will not be able to contribute to the IHR capacities. So that same set of barriers or motivators for FETP graduates is really the same to get to IHR because you have to graduate from FETP and go right into government in a way that you can contribute to those capacities. And I think today we heard so many wonderful examples, Zimbabwe, Zambia, all the different countries that were discussed today where there is that progression from graduating FETP and going into the Ministry of Health and going into those areas so that the capacities are being strengthened by the FETP graduates. So as long as that happens, then they will be contributing to IHR. But if graduates don't have a path into the government systems, then they'll be sidelined and they won't be able to contribute to those capacities. So I think the key really is some of the same things of making sure that graduates have that career path into government. And that's why I think it's so important that FETP is housed in the National Public Health Institutes or part of ministries of health so that that progression is very natural to go from graduation into government and into pandemic preparedness, which will strengthen IHR. Thanks.
Thank you. I hope you are preparing your questions. But at this time, Dr. Ashley from UKHSA. COVID-19 was a real test on our public health workforce needs. What did we learn, and how do we ensure adequate public health workforce for surveillance and response as per the IHR recommendations targets? Over to you.
Thank you, Chair. And thank you for the invitation to be part of this panel. It's an honour. So, I have 4 points to make. Firstly, COVID highlighted the gaps in our workforce, and we're all aware of this. So we need to keep working to fill the gap. The public health workforce is hugely dedicated, but people are being burnt out. How do we fill the gap? Well, one of the ways is to keep making the case and showing the value of the work we do. And I think that's been really well demonstrated here today. My second point is related to digital health. I think for me this is about working smarter, not harder. We need to continue to invest in digital health, but also we need to build those systems with surveillance in mind. And that means engaging FETP alumni and those who are going to be involved in analysing the data and utilising those systems in the system design. And those systems need to be well integrated within the health system and not seen as an optional extra. I think one thing to say on that, on a related note, is it's great to see this sort of increasing accessibility of programming for the non-IT experts and epidemiology colleagues who may not be IT experts but can actually get involved in automation activities, coding, code sharing, and I think this is a really positive thing and can help us to work smarter, not harder. The third point to make, so COVID required an all of government, all of society approach. And we all grow up in our professional disciplines, but it's so important to work and think across disciplines. We need to learn to speak each other's languages. We need to continue to grapple with finding the right emergency coordination and governance systems so that we can be working towards the same objectives across different sectors. And I think in this regard, it's great to see FETP attracting professionals from different backgrounds and also FETP graduates working in different sectors. And then the final point is really just to amplify, I think, the message of this event. We need to stay connected and stay current. We are all connected. COVID taught us that, and also that we need to keep learning. My FETP network in the UK, my FETP program led to a network in the UK and also a network across Europe. In the beginning of the pandemic, our WhatsApp group was not stopping. We were sharing information and resources, and it was such a valuable network. I think our alumni network is young. Our program is relatively young, so I'm taking lots of notes from today to take back to the group. But I think it's just to say that these events are really important, and congratulations to ZAFENET and to the organisers. Thank you.
Thank you, Dr. Ashley, for that great response. We move to the next panelist. This is to you, Dr. Simon Antara, Director AFENET. What strategies can be implemented to ensure ongoing engagement and participation of FETP graduates in public health initiatives? Over to you, Dr. Antara.
Thank you very much. Let me also add that I'm an FETP graduate. And let me take 1 second to, on behalf of Patrick and on my own behalf, to acknowledge a great teacher of ours. All those who went through the Kenya FETP, the early days know that Henry Walk, who is here, really contributed to bringing us a thanks, Henry. Now I think my 3 ministers now. The subject of involving or FETP graduate participation in health initiative is one that has been widely discussed, and we have common agreements on what should be done. But today I want to approach this subject from a different perspective. One, this should start from the training. We must ensure that field epidemiology training programs have the capacity to offer high quality training. This is very important because graduates with high quality training, graduates with great skills that are contributing meaningfully to national, to continental, and to the global public health agenda, they become great forces of attraction and create the demand for FETP graduate involvement in health initiative. There is no branding that is as strong and no advocacy as powerful as excellent delivery. Number two, there must be deliberate effort, policies by ministries of health and other relevant sectors to place and retain graduates in strategic positions. This brings them close to health initiatives and allow them to apply their skills to support the attainment of positive health outcomes. Number three, FETP graduates should create a recognized presence in the form of alumni associations in their countries, and I'm very happy to hear about what ZAFENET and to hear about what other FETP alumni associations are doing. You need to create a very strong, recognized presence. Alumni associations allow for recognition, easy reach, and engagement by health authorities and partners. It allows for accountability of the work of members and associations and build the credibility of the group. As we all know, accountability and credibility are essential elements for continuous engagement. These are the reasons why AFENET, we invest in alumni associations. Number 4, at continental and at global levels, the creation of platforms to provide for networking and cross-fertilization among FETP graduates and among alumni associations is critical. AFENET is a network of field epidemiology training programs. We should have another platform that allows for the networking of graduates of field epidemiology training program. And that is why AFENET, we created the AFENET Corps of Disease Detective, which is essentially a network of field epidemiology training program graduates in sub-Saharan Africa. Through ACORD, these graduates can be rapidly mobilized and promptly deployed within and across borders to respond to various public health issues, and by so doing, offering them the opportunity to be part of health initiatives. Through ACORD, we share information with graduates and provide continuous learning opportunities to ensure knowledge and skills upgrades, thereby enhancing their continuous relevance and participation in new public health initiatives. The African CDC AVOC is an important network of continental responders. ACORD and FETP graduates, for that matter, have benefited greatly from many opportunities provided by AVOC, and this has given them opportunities to be part of many health initiatives. Finally, I want to say advocacy is very important. At all the levels, all stakeholders of FETP, we must advocate for the use of the great expertise that these graduates have. FETP graduates have what it takes to contribute to whatever it is, global health security, universal health coverage, the triple billion, whatever we can talk about. FETP graduates have what it takes to contribute to that. Indeed, for Africa, FETP graduates have what it takes to contribute to a healthier, safer, and a more prosperous Africa. FETP graduates have what it takes to contribute to the AU Agenda 2063, the AFENET we want. The Africa we want, rather. Thank you.
The FETP we want. Okay, so as we get to Samuel, there was a question we were to ask Dr. Lul on funding and sustainability. I want you all to think about it, and it should be part of your closing thoughts, or one of the audience members should ask that, because it's an important issue to tackle. But Samuel, I know you are very effective in networking and creating opportunities for FETP graduates to be used in health system strengthening, to advance public health practice, research policy, and ultimately improve the outcomes, health outcomes for population. What are some of the potential challenges or barriers to effective networking and utilization of FETP graduates, and how can we overcome this? Over to you, Samuel.
Thank you very much, Patrick. I don't know why you are always fond of setting me up. He has said so much about me in networking, and if people don't get what they're expecting based on what he said, they get disappointed. I'm not even a professor. So I think I'm going to fall within the 3 minutes time. There are two issues there. One is on the barriers to networking. And we all understand that networking is based on the principle of peer interaction, where the two groups come together and there must be a mutual relationship. One challenge, which I think is germane, is that of platforms. There must be a platform for the individuals to meet. For example, our meeting here is a platform. I'm meeting some of my colleagues that we've been meeting for some time. Some we've not met. I'm meeting some for the first time. We've established a relationship. It means that in the nearest future, the opportunity comes for us to discuss. I know whom I can always reach out to in the various units for us to discuss on those issues. But the question now is, how many of our colleagues can afford being here? I came from the US and I know what it takes for my organization to have funded me here. Assume an individual were to fund himself here. Some came from the neighboring countries. Coming here is a privileged meeting because you must have the resources to be here. What about our colleagues that don't have the capacity to be here? So it means that there must be platforms and there must also be avenues to support people to access those platforms. It might not necessarily be at this level, at the international level or national level, the way it is now. There must also be platforms at the national level and sub-national levels. And people must have capacity to access those platforms to meet their peers before we talk about networking. And I love the idea of the recent direction of virtual networking. In my organization, we have what we call the TEFI Connect. TEFI Connect, the largest single body of alumni that galvanizes all FETP graduates together. Within the organization, we also have the use of Basecamp, where we use to reach out to all our colleagues in the field. And it provides them the avenue for them to interact and then ask questions and even to share opportunities with them. So these are some of the low-cost resources that we can use. The use of virtual platforms for networking. Now, apart from platforms, we also have the issue of you having something to offer. In a network, you must also have something to offer. It might not be opportunities, it might not be resources, but you come in a network believing that you have the knowledge. I might have the opportunity, you have the knowledge, and it creates a mutual relationship. Because for you to talk on networking, you believe that there must be an opportunity for one party, and the other party might also have something to bring to the table. But in a situation where you come in empty, you don't have ideas to present, you don't have something to offer, then that's a challenge. And that is what happens to most of us. Most of us might have the ideas, most of us might have the belief, but we don't know how to package what we have. And that is what experience I've got working in North America and Europe. They have very tangible things, but the way they package it, you wonder. And it tells us that for us in this part of the world, we must learn how to package our information. Communication is very, very key. Because you have the message, you have the substance, but being able to pass it through in a network becomes a challenge. So it's one area we must look into. I said I'm not a professor, so I'm going to stop there. Thank you.
Thank you very much. That was our last panelist, last but not least. So we are going to shift gears now. They will still remain there, but now we want questions from the audience. If you have any questions, please. I thought these mics are there.
Just come and give us.
Okay, so we'll take a round of questions.
Well, my concern is, what are the policy frameworks that are critical to firmly anchor FETP in national planning and development agendas?
The question is open source, or one of you will take it.
Yeah, thank you very much. I am Dr. James Sylvester Squire. I'm also a graduate of the FETP program, to the UK Field Epidemiology Training Program. And currently I'm providing consultancy for the task force, and also I'm the national lead for surveillance, disease surveillance in country. My question has to go to Dr. Keno, Professor Keno, and Dr. Antara. From the presentations that was given by our networks from Nigeria, ZAFENET, and Zambia, one of the things that actually I did not see is the involvement of other partners beyond African CDC. This I'm saying specifically for Sierra Leone. We've seen our program is mainly being run by US CDC, and we are not seeing other partners that are actually supporting. Unless most recently that we are having fund from Global Fund to support trainings. So how do we improve on that? Having other partners in country to support the training program beyond CDC. As I speak, CDC have cut down their funding over 85%, and that has actually affected the program. That is one. Then secondly, Dr. Kenu mentioned about motivation for staff to stay. When I actually finished my graduation back home, fortunately there was a position for the resident advisor. I applied for that position, and I believe I actually had that qualification for that position. So what is the criteria for countries? Because it's high time now. I think countries drive their own FETP programs. I think that is more advantageous to the countries, and I think that is what is the criteria in terms of getting that position. Thank you.
Thank you very much for those panelists. So mine is about career progression. I'm surprised we are still battling with career progression. I think we wrote a paper about where other graduates, FETPs, over 8 years ago, and that was the question. And we're still talking about it. So can we try and break it down? What do we mean by career path? For the other professions that have been successful, what exactly have they done and ensured that they have a clear career path? Because right now we are broadening the scope of the FETP. We are talking about environmental epidemiology, we have One Health. So we are magnifying the issue of lack of the career path. So what do we need to do? Are we talking to all the key stakeholders? And for those that have managed to retain their jobs, to get into jobs and retain them, what is it that they've done as an epidemiologist? What are the risk factors that allow you to retain, be attractive? What are those attributes? I think we need to be a little more, dig down and stop looking at career path at a global scale, but break it down into small components, and I think that will make sense. Thank you very much, and it's for anybody on the panel. Thank you.
There was a fourth. Short questions.
Good morning all, and thank you for the presentation. Actually not a public health specialist, but an economist. And I'd like to ask, how are you shaping the field epidemiology programs to be more of, you talk of evidence policing, but we see field epidemiologists are the ones who, in the high time of public health emergencies, bring out the information. But they don't have the time to synthesize the type of data that is required to make evidence. But it's them who can actually provide the evidence that is needed to make policy recommendations that do not come back to bite, like what we saw with the masks. Use the masks, keep distance, then we start looking at the costs from the policy side, and people now start rejecting because it was not based on very sound evidence. So how are you ensuring that as field epidemiologists are being moved and thrust to the limelight of policy making, that they actually contribute so that they can be providing timely information? Thank you.
Okay, thank you for those questions. I think we can give an opportunity to our panelists to answer, but before they do that, there is a line person here. I'll just read it out. What role is AFENET playing in ensuring that the soon-to-be-finalized pandemic accord takes care of the needs of African countries? What role is AFENET playing in ensuring that the soon-to-be-finalized pandemic accord takes care of the needs of the African countries? So we'll give an opportunity to our panelists to react to those questions that were raised by our audience. Yes. And also, as you do so, maybe can you also give some final thoughts in just about under a minute?
Yeah, I think because I'm not a university professor, let me start. I want to try and link the first question to that of the career pathway. using my experience of the sector of the Nigerian FETP. Now, in an ideal situation, if you are setting up a program, there must be a policy framework for that. That's the first step. Then you come out with a plan. And then the plan, it could be strategic or it could be operational. Right? Strategic and operational based on the strategic plan. But because maybe FETP is an emergency-based program, at times the institutionalization also could take an emergency approach. Because if you are talking about a career pathway should be tied to a policy. And that goes beyond the health sector. It's a multi-sectoral approach. For example, in Nigeria, when we were thinking of the Nigerian FETP program for the advanced track, we were thinking, when they graduate, where and how are they going to be placed in the Nigerian civil service? And we started consultations with the Office of the Head of Service, Ministry of Budget, Planning, and this. And the question was, where do we have the resources to pay them at the level which you are advocating for them to be? So it was a discussion that almost started this takeoff of the FETP program. So we decided that, okay, let's go ahead and start up the program. And then we'll continue with these consultations. Because our expectation was that somebody graduating from the advanced FETP, when coming, should come in at the level of the assistant director. I think that level was 16 in the Nigerian civil service. But then people were looking at it. How do you expect somebody who goes on a 2-year training to come in and then be a boss over those that have been in the service for over 10 years? And they've taken masters in other disciplines. And then the Ministry of Finance question was, where do we have the finances to pay the salaries of these crop of workers? So it became an issue. So to your question, yes, there must be a pathway for them to grow, but at times, and in most cases, it goes beyond the health sector. It's a multi-sectoral sector. And that is why when I was talking with the head of AFENET here, he was talking about executive FETP program for Liberia. Then I just told him that maybe I will tell you that we should start executive FETP for African politicians, because they are the decision makers, they decide. Or that you spend 10, 20 years learning, a politician could sit down in an office and within a minute use a policy that goes down. So we should have a FETP policy, AFENET head, targeting the African politicians. Because in Africa, they are the decision makers and they are the implementers. And that will help a long way to drive forward the idea of career pathway. Thank you.
Thank you. And I want to echo that. I wanted to address the question about the policy framework, which is, again, the same point. I think all the FETPs that get started, I don't think we've thought ahead on this career progression. This is why we're in this problem. And I think that now we're starting to see that job requirements say you have to be an FETP graduate to get this job. And then that's at a district level or at a state level or at a national level. And that those are the requirements of the job. And you can't get the job otherwise. And that will add to the progression, because you obviously can't get the job without the degree. It's not a degree, but without the credential of FETP. And I think creating those paths and those requirements will get that career progression and create that policy framework. And I think that acknowledgement of the importance of this training in policy making is also gets at the last question, which is that the data that come from the investigations and the work that the FETP residents and graduates do should feed right away into policy development and right away into the frameworks that are shaping public health in a country or in the region. And so I think that government recognition of the importance of those data is what will shape the policy And the government recognition of the career path will shape those job requirements. And it all comes back to what you just said, which is the leadership of the country. Are they on board to making those kinds of changes? And I think the example of Zimbabwe, what we've seen in Nigeria, Zambia, there are many examples, more and more examples, where this is actually starting to happen. And I think it's really gratifying to see those changes. And it will make a difference for FETP career progression, but it needs to be pushed, and by the politicians. Thank you.
All right. Having more partners beyond the US CDC and Africa CDC funding FETP. So first of all, I would like to thank the US CDC for funding FETPs in Africa over the years. I am not aware of any single FETP program in Africa that has not benefited from technical and financial support from the US CDC. I also want to thank the Africa CDC. They have taken up FETP very seriously, and is part of their strategic plan to support workforce. And in workforce, they have particularly mentioned the support for FETP. And it's not only that, they've started providing resources to AFENET to support FETPs. So I really want to thank the two CDCs for all this great support. I want to say that FETP is one of the best gifts that the US CDC has given to the world. It's one of the best gifts. A training that combines the right knowledge with the right skills and with the right attitude to deliver various public health services. That is the kind of training everybody needs, and particularly Africa. That is the training we need. And this is the training that is offered by FETP. A great gift. So what do? We have a responsibility to make sure that we keep this great gift alive. Now, one of the biggest challenges is that we have many FETPs now. The funding from the major sources, or the major source, actually the USCDC, has gone down a bit, and we understand why. We know there are usually the ups and downs, the valleys and the mountaintops when it comes to this funding. And so the need to have more partners beyond this is very important. And I want to say, yes, we've started getting that. You know, the Global Fund has what they call the C19 response mechanism, the COVID-19 response mechanism. And through that mechanism, a number of countries have been able to source some resources to expand or to start FETPs. We also have the PMI that has been supporting, President Malia initiative has been supporting FETP. The World Bank, through what we call regional disease surveillance system enhancement in West Africa and Central Africa, has supported FETP development. And also some projects incorporate among it some funding to support FETP. Yes, I must say that we need to expand, continue to expand the partnership, because it's very important. We need to trade more. The gap is still huge. But what we should also be talking about is at national level. And I'm happy that somebody talked about the issue of national development plan, inclusion of FETPs there. If the country puts this in there, it becomes a priority for the country. And therefore, there will be allocation of resources. So we need to actually engage in the discussion beyond just the Ministry of Health, because it has become very difficult for the Ministry of Health to do the things we've been asking them to do. How can we go beyond the Ministry of Health to the Ministry of Finance and to the National Development Plan?
The same things about kind of professional identity, where it fits, job requirements, etc. We have an older program of registration of general public health specialists, and there are various sort of initiatives to register these professionals at different levels from both medical and non-medical backgrounds. So yeah, I guess one thing I would say about how to build that is about the professional community. I think that was what led to these earlier initiatives. It's about the professional community coming together, showing your value, and then also reflecting on your identity. I think there's no FETP, as we all know, essential it's essential training, it's essential skills. It's also not sufficient for a public health system. You know, we need to work multi-sectorally. We need to work with all other disciplines. And so, where do you see your identity? Where do you see you fitting in the systems? And one thing I will just finish on, and it's related to this point about getting evidence into policy. I think the future of this profession is intimately tied with the development of strong public health institutes across the world. I think these institutes serve that key function of informing, of using science to inform policy, not just blindly following the science, but using informed science to inform policy, and embedding that at all levels of government. So I think our journey as a profession is tied up with this one as well. So thank you.
They have answered all the questions. So, in summary, the aspect of unpacking the career progression issue, I think we need to take our time and look at it carefully. And one of the reasons is because the salary structure in most African countries are based on your primary degree pathway. Now, when you come to FETP, you are having a mixture of them. When you prepare a career path and salary structure of it, it's confusing. And one thing that the government in any country will not do is have instability on the workforce front. That is why we are having this challenge. But I believe gradually that we will get there. But it's just a matter of we unpacking it and then presenting it to them differently. Well, in conclusion, it is the interest of all of us, both international and national entities, to motivate FETP professionals to be in their respective countries and also continue doing the work they're doing. It is easier to put out a small fire than to put out a big one. Thank you.
I'm sorry we didn't have enough time to interact, but I think the core issues have emerged, and I want to call upon Dr. Nyambe to sort of close this side event. Thank you so much, our esteemed panelists. Please just remain seated there as we get to the final section of this.
Thank you so much. Very difficult to close when big people have spoken, but I'll try my best. I think when we talk about descriptive epidemiology, we normally talk about the descriptive phase, the analytical phase, and the response phase. So if you look at this discussion, our key topic has been the FETP. We can have 4 Ws also from that descriptive phase. First W can say, who are the graduates? So this is the alumni we're trying to track down today, the graduates. The second W can say, where are they? We are trying to answer this question, where the graduates are, by trying to really locate them, the geomapping. The third W we can ask is, what are they doing there? Yeah, we can ask ourselves those important questions because we need to ensure utilization of the graduates. Then when we move from the descriptive phase to the analytical phase, we need to answer the questions, why? So why are our graduates there? If they are there for the wrong reasons, then we need to find solutions for them. When we go to the last phase, the response phase is, what are we going to do about it? These problems that we have seen with FETP, what are we going to do about these problems? We know where the graduates are, we know what they're doing, they're not doing the things they're supposed to do, and we have these problems. How do we analyze what is contributing to their low motivation? Why are they not being utilized? Where is the funding? Where can we find career paths? This is what we're trying to unbundle, and from this discussion, this has been a very rich discussion. So strategically, we invited the AFENET to come, and strategically, we invited the leader of the Journal of Epidemiology and Public Health to be here so that we can transform this discussion into a powerful publication that people can reference to. These are important solutions, and we don't want to take these solutions for granted. We know that it has been difficult to assemble this team This team that you see here is not an easy team to assemble. It's very, very difficult to pick each of them here. If I can start one by one, from Professor Ken. Professor Ken was in Mombasa for the AFENET conference. From the AFENET conference, straight he went to Nairobi. He went to Ethiopia for the Africa Epidemic Service meeting to develop curriculum. From there, he came straight to Zambia. He has not been home for 1 month. You see how important it is. If you go to Dr. Adara, he's just running away from a very big conference. More than 700 people. It was not easy to pull all these people, find resources, air tickets for a lot of people that traveled. Some also is running from the USA to come and join us. We would have also had Dr. Kao already joining, but he's only arriving later on today. Dr. Kala is not a very easy person to access, very difficult. She's very big there in the USA. So having this opportunity to see her and interact with her is a very, very rare opportunity, and we do not want to take advantage of that. Our UKHSA country lead has just arrived in Zambia. He hasn't even settled down. I only met him today. So you can see how difficult this panel has been to assemble. Our moderators, Dr. Gombe is a very busy man. Dr. Kenu here, very experienced, that you see how he has engaged us. These are not difficult. These are not easy persons to easily pull and engage. But we have managed to pull them, and we have managed to bring them together. A big round of applause for them. So that we can only say thank you and thank you so much. Also, I would like to thank you for everyone who is here. I think this has not been an easy thing to organize, because the registration was happening today and you had to be here and you had to register at the same time, but we still managed to gather together. And I would also like to thank the 69 people that are online. Thank you for managing to join in, and they have managed also to connect. A big round of applause for it. Just to show that this is really an African conference, I'll try to say thank you in various languages. I know I can say Asante Sana. I'll represent most of the people around the East Africa. I can say Webale Nyo from Uganda, Kampala. I can say Akwaba from Ghana. I can also say Nyansei from Nigeria. So this is so thank you so much, and of course not forgetting Messi. So one last announcement, we have a group photo, and then please, we want to have feedback how this side event has gone. Please take a screenshot, the QR code is there, give us feedback to make our next event, of course, much better by ensuring that we can get response from this side event. Then finally, I would like to say thank you to the UKHSA for sponsoring this side event. A big hand for the UK. Thank you so much, and bon appetit. Enjoy your lunch.